Lateral uni is comparatively very less in comparison to the medial uni. Even in fact, I have done only 12 cases of lateral uni. So how do we identify? Because in fact, it is 3% of osteoarthritic patients that we are encountering. And maybe we are not able to identify because the disease is in flexion. So we need to take varus valgus stress X-ray in 30 to 40 degree of flexion. So indication, we know it is exactly same as a medial OA, where the full thickness loss and the literally good joint space maintained on medially and no significant radiological patellofemoral arthritis. The very good thing that Dr. Mullaji said, the range of movement has to be around 90 degree. And when we are doing a lateral uni, ACL has more value. Of course, weight is not a criteria, but above the BMI 35-40 should be avoided. So always take varus stress X-ray when we are thinking of doing lateral uni. So now certain things that are little different than medial uni. So in lateral, if you are thinking of lateral uni, it is a disease in flexion rather than in extension. So if you see the involvement of the posterior condyle of the femur or the posterior part of the lateral plateau is more affected. And second most important thing, when we are from extension to flexion, the tibial component rotates, or not the tibial component, even in natural tibia which rotates around 10 to 20 degree of internal rotation. So the placement of component is little different than medial uni. Usually patella is less affected as compared to the medial osteoarthritis, and we need to understand when there is a congenital deformity or inflammatory arthritis, we have to avoid doing lateral uni. If there is a degenerative arthritis or post-traumatic arthritis, then we can definitely go for lateral uni. So right indication is, in some young age there is an injury and arthroscopically lateral meniscus has been removed, and that is the ideal indication where the anatomy of the femoral and tibial component is normal. So now we need to understand the anatomy. So if you see the medial and lateral condyle, the lateral condyle is quite behind the tibial, the patellar tendon. So when we expose the lateral condyle from either laterally or medially, the patellar tendon covers a lot. So we need to understand the anatomy, and the cutting of the tibia is little tricky. So when we want to cut the tibia, we need to see that our cut is absolutely perpendicular to the intercondylar line. So if you have not retracted the patellar tendon properly, we ultimately might end up cutting our cut in external rotation, which is more dangerous in lateral uni. Our cut has to be absolutely in straight line, or it should be internal rotation of 8 to 10 degree. So that is very, very crucial when we are doing a lateral uni. Even in the femur, the anatomy of the femur, medial and lateral condyle is little different. And here our femoral component has to be 3 to 5 degree of external rotation, so that when we flex our knee, the alignment of the tibial and femoral component remains in a good position. The third important thing is when we flex the knee at 90 degree, the lateral compartment opens up. So even when you are doing arthroscopy, when you do a figure of 4, and then you will be able to pass 5 millimeter of scope easily, so that our component should be little loose in flexion, maybe 1 or 2 millimeter, not very loose. So what are the tips and tricks? It should be, what I prefer is a midline incision, mini-lateral parapatellar approach. Keep the tibial component in internal rotation, keep the femoral component in external rotation, and balance 2 to 3 millimeter legs in 90 degree. Of course, it has to be 0 mm in full extension. So this is a typical lateral parapatellar approach. I always take out some part of the patella so that exposure becomes easier, and release the tensor fascial lata, so that you will be able to do a good internal rotation of the tibia, and you will be able to expose the tibia very well. You can see the tibia is exposed very well, and then use the tibial jig. Now when we are using a lateral parapatellar approach, you may not be able to cut, as I said, it may be in external rotation. So use a burr to reach to the central line and see to it that it has been cut properly. Check with your trial tibia and see to it has been placed properly. Then you prepare the femur, do a trial reduction. Whether you are doing medial or lateral, you need to see to it that you don't put too much of cement, because it is very difficult to take out the cement from the posteriorly. So you have to be very careful. Cementing, it's little different than total knee replacement surgery. And again, you don't have to hammer very hard on tibial side, because there is a possibility of the fracture. So you have to be very, very careful. Of course, we do the final cementing, check everything. There is no cement around, so we have to be more precise. So the technique, again, I'll more emphasize on this, is a proper internal rotation of the tibial base plate in relation to the femoral component. So we do a 8 to 10 degree of internal rotation of the tibia, 5 to 7 degree external rotation of the femur. Even here it is little different. I mean, in medial OA we take out the osteophyte first. Lateral OA, we keep the osteophyte, which help us to keep the femoral component in little external rotation. Medial resection to reconstruct the entire lateral plateau, so you might have to use a burr, or even patellar tendon split approach people are doing, which I have never done it. I am little worried about it. And you should have an enlarged surface area to resection to prevent subsidence of failure of the tibial component. So it's 1 year follow-up of 67-year male patient. You can see the valgus stress, varus stress, and then post-operative, immediate post-operative picture. So in conclusion, correctable deformity, normal pre-disease anatomy, which is very, very important in lateral OA. Medial compartment and a patella should be normal. External rotation of the femur and internal rotation of the tibia, as the anatomy is little different than the medial OA, and keep knee in 2 to 3 millimeter loose in flexion. Thank you.